Welcome to Oncology Now. I'm joined by my colleagues here today in Knoxville, Tennessee. My name is Alan Tan. I'm at Vanderbilt-Ingram Cancer Center in Nashville, Tennessee, and an associate professor in Oncology. And I'll go around the table and
I'm James Bienvenu. I'm a urologic oncologist at the University of Tennessee, Knoxville Graduate School of Medicine.
I'm David Chism. I'm a medical oncologist for Tennessee Onc and Alcoa.
I'm Saikrishna Gadde. I'm a GU and GI medical oncologist, and I work at the University of Tennessee as well.
My name is Wesley White. I'm the professor and chair of urology at the University of Tennessee, Knoxville.
Nilesh Patel, radiation oncologist at Tennova Healthcare here in Knoxville, Tennessee.
so we're going to be talking about advanced prostate cancer today, and so much has changed in metastatic castrate-sensitive and hormone refractory prostate cancer. So many novel tools that we have at our disposal today. And we're going to be talking about the nuances about treating these patients today. And it's great that we have a multidisciplinary team of radiation oncology, medical oncology, and urology. So I thought we'd start with a patient case just to really go through the workflow of how we see these patients, who we refer to, and when we refer to in these different settings. So let's start with a patient that's 65-year-old, and he comes with a PSA of 7. His wife decided to, ask him to get PSA screening because his primary doctor had not been doing it regularly. So now he has elevated PSA and gets referred to urology. So, James, why don't you talk to us about what you start with these patients and what kind of diagnostic tools, and if there's any precision diagnostics that you like to use? Yep.
Sure. So typically when we see an isolated elevated PSA, we're going to repeat the PSA. We're going to confirm that it's real. In today's practice of elevated PSA, those patients, if it's confirmed, are going to get a multiparametric MRI. They're going to get a digital rectal exam in the office, and we're going to look for abnormalities that would push us towards biopsy. If they've got a confirmed abnormality, then they're definitely getting a biopsy. When he was how old? 67.
Yeah.
So he's probably got a 10+ year life expectancy. Every once in a while, we'll pump the brakes if the patient has a negative multiparametric MRI and a normal exam, maybe a big prostate, but we're going to monitor them until the point where we get to a prostate biopsy if it's indicated. And then that's going to drive our next decision making.
Okay. And I know there's a lot of new diagnostic tools, molecular diagnostic tools, something like the Decipher test or maybe Artera AI test. Wesley, do you have that in your practice? Are you using that regularly to decide or prognosticate?
Yeah, I tend to divide it into kind of several buckets. One is in the pre-diagnostic setting, and the other is in the post-diagnostic setting. So as James had mentioned, yeah, I'm a huge believer in multiparametric MRI, repeating the PSA, as he said, letting the MRI guide, by and large, whether I would recommend a biopsy or practice some strategic patients. If we do get to the point of finding an abnormality or doing a prostate biopsy, the approach on how I would do that prostate biopsy is contingent on what the MRI shows. So whether that's a transperineal approach, a transrectal approach under conscious sedation, fusion-based biopsy, all of that's on the table. If that individual is diagnosed with prostate cancer, then I think in the post-diagnostic bucket, that's where I'm using a lot of those molecular studies to help guide, especially in the low to favorable intermediate risk group, the role of potentially androgen deprivation therapy in the primary treatment with radiation, whether a patient's a good candidate for active surveillance, and the like.
Got it. Okay, so let's say we repeat the PSA and it's now 8.2, and then the patient goes on and gets the biopsies by James, and it's a Gleason 4 + 4 = 8, so high-risk prostate cancer. What are you guys doing next? Are you guys using PSMA PET scans these days on all your patients?
If we're allowed to get a PSMA PET by whoever, maybe their insurance provider, they're going to get a PSMA PET up front. Rarely are they, especially in the high risk grade group 4 prostate cancer, denied, because the NCCN guidelines are pretty clear that it's preferred and they need bone and soft tissue imaging. So we don't have too many problems with that, and I think it's a super helpful diagnostic test when making decisions on treatment.
Right. So we hear this term of stage migration now because in the past we were using conventional imaging with bone scan and CT scan. Are you guys still using bone scan and CT scan regularly these days, now with PSMA PET being more widely available?
I see them from community referrals where people sent over for evaluation for prostatectomy and the like. We'll still see CT and bone scan, but it is becoming less and less.
So I know that it's probably not feasible or practical that we do conventional imaging and PSMA imaging, and maybe we can't do that because of cost. But let's just say we had a conventional test that was done, and then they came to you for a second opinion. The conventional test was completely normal bone scan, normal CT scan, but then you have one node positive on a PSMA PET scan. What do you guys think? Do you guys bring this to tumor board, or this is something that we, treat as a low volume disease? Or what do you think, Nilesh?
Yeah, so I think obviously if we see that on a PSMA PET scan and a Gleason 8, then there's a high likelihood that's definitely a real node. And obviously a multidisciplinary approach would be a preferred, but in those cases, I would treat it as a low volume, but local regional disease versus a true metastatic disease. And I think our goal still would be a curative approach in a single positive lymph node on a PSMA PET scan. So typically with high-risk patients, from our standpoint, would be androgen deprivation therapy along with radiation therapy, radiation focusing on the prostate as well as the pelvic lymph nodes.
So Wesley, what do you think? So negative and conventional scan, but you have a PSMA PET scan that is positive there. Would you still talk about a curative surgery for something like that?
I do, although I often, with any high-risk patient, but especially in the setting where you've got avidity on a PSMA PET, I would still offer, and I have offered patients radical prostatectomy. I do talk to them about the likelihood of a multimodal approach, that this may just be the first in a series of steps. We'll move the prostate, do a lymph node dissection, wait pathology, wait the PSA 1 month. If the PSA drops to 0, there's nothing that's pushing me necessarily to immediately irradiate or put on hormone deprivation therapy. That's just my bias. But I do counsel them preoperatively that they have to gird themselves for potentially salvage radiation therapy and hormone deprivation therapy on top of surgery. So I'm very selective on who I would offer surgery to in that setting.
Thank you. So Dr. Gadde, do you know of any other nuances with PSMA PET scan? I know it's sort of a misnomer. We call it prostate-specific membrane antigen test, but there are actually some false positives I'm hearing.
There are some false positives. I think the exact tracer you use makes a difference, and so I think my rad-on colleagues may know some of those tracers better than we do. But I think in some of the institutions that used gallium in the VISION study, and so gallium, is supposed to be very specific and sensitive. It has both components where if you're detecting something, you're sure that represents a true focus of disease. And I think there's other agents. I think there's one that's PSMA 1007. It's a longer name, and that can pick up more benign bone lesions. And so you have to be careful with the agent that you use. At UT we use Polarify, and some of that is a cost analysis as well in what we decide to use.
Yeah, and I would agree with Dr. Gadde. In some of these PSMA PET scans, we've seen more, particularly rib uptake, as being something that's probably not a real finding in terms of metastasis. So we have to be very careful on these agents and how they're read.
Right. And some of the agents may have more clearer on the pelvic region versus if you're looking in the bones.
Right. So Posluma is one that's supposed to have a little bit less splatter uptake. So particularly for salvage cases, that may be a better agent if we're looking at post-prostatectomy, prostate bed recurrence.
Right. And sometimes you may get an MRI, of a certain region just to clarify if that bone lesion is real or not as well.
Yeah, especially rib lesions, based on a UCLA and UCSF study, they did biopsies on a lot of solitary rib metastases, and more than 90% of the times these were negative. So I think, something to emphasize is if you see, don't overinterpret PSMA PET scans, right? Because you may be missing out on the opportunity to cure a patient, right?